Well, thank you, Kathy and Deb. Uh, you all are always very gracious to invite us to this conference. And good morning, everybody, and those here and those here virtually. Um, it's an interesting time in our communal specialties, and my uh, comments are mostly going to be directed towards the perfusion world, those that have been practicing for a long time, and those who are just about to get started. Um, but my belief, which I will emphasize in the course of my few remarks, is that we can all always continue to improve our trade. We are ultimately bedside practitioners, and there are certainly forces at work that can be real impediments. I just yesterday gave Dr. Livesey would be fascinated about this. I just yesterday gave the board exams for the American Board of Thoracic Surgery, and that's a big responsibility to examine cardiac surgeons. But in their infinite wisdom, the American Board of Thoracic Surgeons has decided that being examined in congenital heart surgery, particularly pediatric heart surgery, is no longer a requirement for a basic American Board of Thoracic Surgery surgeon. So I understand that there's good reasons for that, but it calls into question how are we going to continue to refine our craft as landscape, the dynamic of heart surgery changes. And so I find it quite interesting. So today I've decided, this is the third year, I believe, that we've spoken at your conference and joined here by colleagues Eric Leib and Richard Evans, and we're going to sort of, I think, coordinate our comments together in a way. But I decided this year to talk. We've talked about the structure of our program before. We've talked about tiny baby heart surgery. I wanted to go together into this year and talk about adult congenital heart disease, something that I'm very interested in. I think that sometimes it's a bit over dramatized, and so I have strong opinions about where it should be done. So this will probably not be the most perfusion directed presentation that you hear in terms of the latest technology and devices, more about philosophy, which I think is paramount if we think about how we're going to move our mutual fields forward. So the disclosure I have is that I'm going to present some unpublished data. Now, these are highly scrutinized data, as should be the case in all responsible heart centers this day and age. These are data that are reported to the Society of Thoracic Surgeons, which is our sort of overarching registry body. I can't stand in this auditorium and not acknowledge Dr. Cooley. We certainly all loved him very much. I did. We didn't agree about everything. That's really a healthy thing. But we agreed about a lot of things. And one of the things as I've become more experienced, and those who worked with him, Dr. Cooper, Dr. Livesey, others, remember that one of Dr. Cooley's strong opinions was make things as simple as you can. And we see, again, some creep on that mission. Certainly, I have in my career. So just briefly, this is where we are every day. This is vibrant, rapidly expanding community of Austin and Central Texas, and that's given us a platform. We all went there because of the University of Texas, and it's interesting how few people actually know this, that the University of Texas Austin didn't have a medical school until just at a decade. We just graduated our 5th class a few weeks ago, and Michael Dell and the Dell family were present. Michael Dell gave the commencement to the 5th class of the medical students, and it was quite a moving experience. to have the Dell family there, who are the benefactors of the medical school, and see it working together in the greater community of the University of Texas system. And yes, we do consider ourselves integrated into the University of Texas system, and there's a lot of additional opportunities that are developing content. This is the Dell Children's Hospital where we work, also very supported by the family. It's a very different sort of hospital, smaller hospital. We're 300 licensed beds. It does give a little more of a familial feel to a hospital, which we enjoy and have really taken advantage of. We have in the lower right quadrant of this slide, we have a special delivery unit for fetal diagnoses where a large number of the patients we operate are delivered. We had the opportunity to redesign a heart program when we started. We now have celebrated our 5th year, soon our 6th anniversary of the founding, called the Texas Center for Pediatric and General Heart Disease. Back to the comment I made about the American Board of Thoracic Surgery, where adult congenital patients we care for and who should care for them is an evolving question, controversial question. What is the right environment? That will continue to unfold, certainly through the rest of my career. But our observation was a focused new paradigm when truly surrounding patients and families was warranted. And so that's the nascence of our center, and it's been gratifying to see it grow very rapidly. We had some foundational premises, a horizontal leadership structure, which is very inclusive, and complete transparency of all elements of the program, and hopefully a longitudinal coordination way. And we've got pretty large. So this was our program photograph last spring, and it's been fun to see this group come together. A lot of enthusiasm, of course, Austin and the new complex, but also the idea of participating in the new program was attractive to people. We've been pretty busy. We've done just over 2,000 cases, and the results have been acceptable. And this has been all done in coordination with the development of the cardiac program at the University of Texas. So my responsibility now is not only the pediatric heart program, but the adult heart program. Dr. Livesey asked me earlier how many we're up to. So this is our faculty roster. This is the first ever photograph of academic Department of Surgery at the University of Texas Medical School in Austin. We welcomed Dr. George Arnatakis as the first chief of adult cardiac surgery a little over a year ago. He is an incredible aortic surgeon, and we've attracted faculty from around the country, around the world, come to Austin to do heart program. And you probably also know that we're about to build a new hospital, or new hospitals in Austin, right adjacent to the medical school on the former side of the Irwin Center. It was announced a little while ago. Governor, the chairman of the Board of Regents, Chairman Eltife, the chancellor, President Anderson, and the dean of Dell Medical School, along with President Jay Hartzell, President of the University of Texas. It's a really exciting time. One can imagine the Texas Medical Center back in the day when Dr. DeBakey and others were getting things started. We feel the similar sort of energy around the development of the medical enterprise in Austin. So it's fun to be a part of it. Now, we're about a center that takes all comers, and we are people. And again, we see the adult congenital paradigm as part of the continuum. And that's an interesting dynamic. You can see this shift away from adults and children's programs, and now it seems to be recrudescing. Again, I can't say that, reminding Dr. Cooley predicted that 3 or 4 decades ago, just as he predicted that vascular surgery would do this and come back together with heart surgery. Seeing and all considered. It was prescient. I remember he stood up at the Society of Thoracic Surgeons and said it's a mistake to separate vascular surgery from cardiovascular surgery. And now with specialty reconverting. In any event, this is it's how we manage patients at Dell Children's Hospital. It's a community of people focused. That was one extreme, tiny baby, and the other extreme, of course, are adult congenital patients. We've now operated on 125 adult congenital patients since we've been there. That's a very interesting profile of patients. It speaks to the shifting dynamic. So think about this. When I was in medical school, how many patients with hypoplastic left heart syndrome survived at the University of Texas Medical Branch? Well, that's easy. 0. When I was a resident at Johns Hopkins, how many patients with hypoplastic left heart syndrome survived? The answer is easy. 0. When I came to Texas Children's in 1995, how many patients with hypoplastic left heart syndrome had survived? 0. So now we have a whole community of patients who've been palliated with hypoplastic left heart syndrome. They're going to need our care. It's a way, really, assume. This is very interesting. The patients are quite complicated, and some of the data are sobering. We looked at just simple things. We noticed that our patients are big. They're big. So essentially half of our patients are either overweight or obese. Now, there are a lot of reasons for that. Certainly, at the initiation of the program, we did drugs like Ozempic, and that's going to be dynamic to see how that affects the profile of our patients, but complicated. A lot of chromosomal anomalies. Look at this, mental health condition, identified mental health conditions. A quarter of the patients have identified mental health conditions. These are complicated people. They've had complicated lives. Potpourri of diagnoses, some fairly straightforward, some extremely complicated. But they tend to do well. They certainly need it. They need the communal expertise of a focused congenital program. In general, they don't have a very long hospital length of stay. We've had more than our fair share of readmissions. They're often things that are pretty minor in terms of virulence, but it does happen. But the results have been gratifying. We've had no operative mortalities since the program inception. We've had one late mortality. This was a patient that failed funding. Actually, a patient was turned down in centers for transplantation. He was supported for several years, and then we transplanted him, and he ultimately died of quite relentless antibody-mediated rejection. So it's gratifying. So approach to congenital heart surgery, simplify. At present, we think that Children's Hospital are usually the best environment for complex adult congenital patients. Now that dynamic will continue to evolve. These are opinions, but I think they're well-founded. How long we're on the bypass machine and how long we keep the aortic cross clamp on it is usually not relevant. If we adhere to the principles of sound microprotection and precision pulmonary bypass. But meticulous hemostasis is paramount. Careful, accurate, Halstead principle surgery will serve patients well, but it's going to take time. So when we do these operations, we usually don't have anything else that is a conflict with scheduling. And it's very rare for a massive transfusion protocol to be initiated. These patients are out there. Some of them are orphans, and this is one, I know Dr. Gottlieb will speak about this patient as well. This was a patient that came to us from Florida. Wonderful. He was a lineman for the power company in England of his life. Yes, he was a smoker, and he liked to have a few years. But a wonderful guy, finally achieved his just retirement and moved to Florida and became progressively breath and came to be found to have an undiagnosed partial and ambulatory venous return. And this individual really was heart-wrenching in that he went to multiple centers, including some very storied centers, for the consideration of cardiac surgery. It was turned down, and eventually made it to us. Basically, bended knee. I need help. I'm able to enjoy life. So we cathed him. He had a significant QS, a significant shunt, and it was actually quite a straightforward operation. The patient did very well. Afterwards, we did a Morton operation, translocation of the superior vena cava, and intracardiac baffle to redirect the pulmonary venous return. Did very well. Extubated in the operating room, short hospital length of stay. Imagine this poor man was out there floating around, getting attention, and he very happily moving home at that stage. I saw him in the clinic, and we hear from him now annually. These sorts of patients find the right place for care. But the more complicated ones, and this is the lion's share, patients have had a lot of previous surgery. So of the 105 patients, 115 had previous sternotomies, and you see here the numbers. Some of them, many previous sternotomies, as many as 7. And a question, of course, is how many sternotomies can a patient have in their life? Well, it's unanswerable, isn't it? It's unanswerable. We will see. But certainly patients with more than 2, more than 3, more than 4 sternotomies are out there, and they're going to need focused care. Of that group, we've had one major cardiac vessel injury and a repeat sternotomy, and that was at my hands. We got into a very large internal thoracic artery on a patient and had to initiate. Host would like you to unmute. This patient, we were able to resuscitate, move right through the operation. Our approach is not to prophylactically cannulate the groins, not to prophylactically put wires in the groins, not to prophylactically fancy peripheral cannulation. Our approach is to take it, get back in the chest safe, standard conventional cannulation. And if one does this, irrespective of the length of the operation, one can expect good outcomes. So here, our approach plans for longer operation and high patients. As I said, we need to be familiar with peripheral cannulation techniques, but it's usually not necessary. Customized perfusion, what does that mean? We could talk lengthily about that. What we've learned is, just as in an maybe a multiple reoperative adult with collateral burden, complicated systemic venous return, et cetera, we have to have a customized perfusion strategy. Myocardial protection, I still use integrate crystalloid for the majority of the patients, full topical cooling. Your friend, we don't do a lot of fancy cardioplegia, et cetera. It just hasn't been necessary. We haven't had any reason to change. And this is hopefully a point of emphasis that you're hearing. These patients should be part of the continuum, precision integrated congenital cardiac. They should not be held together. And we certainly am going to do everything to resist that tendency you see feel. So this is more. This is patient. So this is the other extreme. So this is a woman, hypoplastic left heart syndrome, weakened mitral atresia. He came to us after 4 previous stenotomies elsewhere in the country. Palliation, Norwood operation, stage 2, bidirectional Glenn shunt, stage 3, extracardiac fenestrated font change. First time she had a device placed in the fenestration. She had an epicardial pacing system. She developed a neo-aortic aneurysm, 11.5 centimeter aneurysm. And unfortunately, now you know that a neo-aortic like this is not negative tissue. is probably pulmonary homograft tissue than it was in her. So it's subject not only to an enlargement, but it's also subject. She, along the course of time, developed at least moderate aortic insufficiency. We had a degree of residual arch obstruction. She had preserved function. And, oh, by the way, she had a severe acquired pectus deformity. So this is her coronal view. You see ascending aorta, calcium dilated. And then the sagittal. That was about 16 years. And this, is that showing up there? Yeah. And this outpatching was essentially a pseudo, found later, essentially a pseudoaneurysm of the degenerated pulmonary artery. So Fontan circulation. And here's some 3D reconstructions of the situation there. There's some aorta and arch. So the question is what to do. This patient too received a lot of opinion, and primary cardiac transplantation, including primary pectus repair before surgery. We felt, and most that the risk of was quite significant. So how would you approach a patient? I think each of us should think about it. You dissect out the groin, into the groins, expect an alternative cannulation, long catheter from the neck, catheter from the groin, vacuum assist, circ arrest, anti-cerebral perfusion, some alternate approach. Well, we felt mostly. So we did standard repeat sternotomy. Yes, it took a while. Yes, we had to use multiple. Groins weren't prophylactically accessed. We saw an 8-millimeter DAC venous artery that it's an 18-French EO. Direct separate cable installation, 20 degrees, antegrade cerebral perfusion, ascending aorta, we suspended the aortic valve, no circ arrest, 6 minutes of ACP, extubated on the table. These are the sort of patients able to come up with a salient, rational, simple, where possible approach. It doesn't have to be. Now, this is the surgeon's opinion, and I'm emphasizing this is my approach of these. I'm not speaking for our institution, I'm speaking for mine. The hard question, uncomfortable question, continues to be, this is my experience in my career in multiple centers. The question is, the perfusionist is a perfect colleague, the vendor technician. And I will tell you, this has been a fight that I have fought every step of my career. Baltimore Clinic, Texas Medical Center, Austin, Texas, a consultant in multiple hospitals. Now that's a personal choice. The personal choice of a perfusion. What is the perfusion service for me to refine the practice? How do you practice your craft? How do you're improving? Do you meet as a team? Do you discuss the patients as a team? Or are you meeting the patients in the operating room? Do you see the patients post-op? You assess the effectiveness of the perfusion service to the well-being of the patient. What metrics equate with optimized perfusion? Low lactate at the end of the case, lack of a transfusion, et cetera. It's certainly almost a personal question, isn't it? Are you a formulaic perfusionist, or do you provide precise physiologic centered strategies? Well, I will never go back from what I learned. I went from teaching as a house office, essentially formulaic perfusion, I would say at a level of hindered perfusion to precision perfusion in Australia, and the difference of outcomes was shocking, not striking, shocking. And continue to preach this and will continue to preach this as long as I'm given the privilege of the podium on the subject. So that started a 30-year process that asks this question: what is the perfusionist role in this continuum? What is the role of the perfusionist? Certainly, you can turn it on, turn it off. You can provide the equipment, you can provide a level of consistency, but are you an integrated professional on a team of complicated patients? This was the epiphany in Australia, seeing people that were completely integrated into the program. So we brought that to Texas. Cooper was there. It was a challenge to change the dynamic. It was a challenge to go from a perfusionists who were all excellent, but not committed to the program, to these dedicated individuals. And I was reminded, so Deb, Mary, and Mary Claire were the three amigas who got things started. I was looking at some slides. You'll be happy to know this, Mary Claire. These three ladies did 500 pump cases a year, just the three of them. They were busy. When our clinics complain these days about being worked too hard, I don't think so. I don't think so. And then we were fortunate enough to attract Richard Owen subsequently, and he's still with us all these days later. These are the early days across the board. Integrated, defined practice. This was a fight. This was a challenging proposition to go from simple, basic setup to deliver accurate perfusion, and then the evolution now 30 years later, which is something that's ultimately integrated. Children's in a recent case. So I could have the same conversation about tiny babies, have the same conversation about complex advanced age. It's about precision, it's about expectations, it's about integration, constant refinement, and execution. So the methodology, the details of the operation, customize a perfusion strategy, assess the overall perioperative management. Yes, I do think every perfusionist should see every patient post-op, see how they're doing. It's, of course, enormously gratifying to see your patients as they move through the hospital. And bring your best, compromise. Tiny baby, cannulation, handle this one in the morning, adult afternoon. And these are some final observations I'll say, having looked at a lot of different programs, the vision of those that perform at the optimal level, patients always first. Now, a lot of places say that, we see it on the billboard. We see it on the billboards driving in Houston from Austin. Every place is excellent. Is every place excellent? Hard question. But you can feel it. You're a place where humility is paramount, service is paramount. It transcends individual or the fabric of the institution. As I said, easily said, not easily achieved. So I'll leave you with telling medicine, adult congenital heart surgery. The patient should be part of a precision continuum, not held in isolation. They shouldn't be differentiated from the tiniest baby. It's an interesting paradox. It's to suggest that one cannot take care of a tiny baby, but one can care for a complex adult congenital. I don't think so. I agree with Dr. Kuhl. We should do everything we can to become the left-hand doctor, the big toe doctor. It's high expectations, limited drama, but the need is going to continue to. The cases we're taking care of, imaginable was a trainee. Well, they weren't part of the section. Who knows what they'll be like to follow. So again, thank you very much See, Deb, everyone, congratulations on this continuing stuff. And it's a privilege to be